Good morning, friends. I am Dr. Narayan Bhusal, urologist. I am currently practicing in Kathmandu, Nepal, and I would like to share my experience with you regarding percutaneous nephrolithotomy (PCNL). And in this short video, I would like to share with you with different uh, approach of kidney from upper calyx, mid calyx, and lower calyx, as well as I would like to talk about a bilateral PCNL, how I do my bilateral PCNL, and a different instrument. I have been using standard PCNL and mini PCNL as well as super mini PCNL because it's PCNL is a very uh, complex topic, and there are lots of different advancement in the technology, and also we have also the understanding of kidney anatomy and variable approach. Each approach has their pros and cons, so I want to explain here because I have tried all these approach in the different time and all kind of scopes, standard PCNL, mini and super mini. I haven't used a micro PCNL, but this standard mini and super mini I'm still using it. So I want to share with my experience how I choose my instrument and how I choose my approach. And there is also now latest we are also using a supine PCNL, and because before we have been doing PCNL in a prone position, so I have also started doing supine PCNL also. But I have a very in any case I don't really make mind beforehand. First I saw the patients, and I saw the I scan, and after then I only make my decisions based on all those findings, because every kidney is different and every anatomy is different. There is no such a things like hard and fast rule, you have to go from this side and you have to approach this way, because all approaches are acceptable as long as you know what you are doing. So I want to first. I used to do a standard PCNL in when I was training. We used to do a 26 frames scope, and we used to do a 28 or 30 frames of sheath. Eventually, that now my standard PCNL is I usually do 21 frames of scope and 24 frames of sheath. Okay, that's my standard now. I'm practice, and my PCNL, mini PCNL, my scope is I think it's around 12 and 10 to 11, and the sheath I use is like 18, sometimes 16, and even 18, 16, 14, even up to 14. And in super mini we have super mini, these systems allow you to do up to 14 and 12. Okay, and for the standard and mini we can use a pneumatic stripper and also laser, but super mini it's still advised to use a laser because it's a very small scope, and laser is appropriate for that. For the puncturing technique, my favorite puncture is always a superior pole puncture, and I will tell you why I prefer superior pole puncture and what are the advantage and disadvantage of the superior pole puncture, what I encountered. Because if let's see, this is the kidney, and we have here superior pole. Let's suppose this is the posterior calyx, superior pole, and this is the anterior calyx. Okay, we can go posterior calyx and anterior calyx as well as okay. But I usually what I do is after catheterization, after this is the prone position, mostly I want to do a superior pole puncture always in my prone position. I don't do in supine position superior pole puncture. And prone position, uh, after putting a catheter or ureteric open catheter, we position the patient in the prone, and I inject the contrast. Okay, and little bit of 5 cc of air I also inject here, and not much air but very little air sometimes. And what happens is once you inject the air will go in the most upper part. Okay, so you can differentiate which one is the posterior and which is anterior by that ear, by looking at the ear, because the ear, in the CT scan, in the fluoro, you will see ear in like a little bit of whitish, okay, white discolorations, unlike the contrast which is the dark. So that's you know that that's the superior pole callus. Okay, so it's very straightforward puncture, and the problem here in superior pole is always this 12 ribs, because the 12 is always in between you and the uh, your calyces. Okay, sometimes the 12 is always exactly in the same plane. Sometimes the calyces are a little bit higher, sometimes the calyces are a little lower. Okay, so sometimes you have to little bit ask your anesthesiologist to hold the breath. Okay, and also sometimes give the expiration or inspiration, so that. And but my in this kind of cases, when there is always drips in front of you, I don't want to go below. Okay, I want to puncture from above as much as possible. So I want my put up punctures above the ribs, because in below the ribs there are lots of blood vessels and there is chance of injury when you are dilating. Okay, and so when I do a puncture here, I try to puncture above the ribs in the posterior superior callus. Okay, and it's always a bullseye technique, because it's very precise bullseye technique and easy to learn, very easy to learn bullseye technique. So what I do is I make a 0 degree fluoro, and I put my point with the needle. I grasp my um, the needle with my what you call so my puncture needle with my needle holder. Okay, so that I will not expose my hands to the radiations. So by this doing this way, I put my puncture just exactly where there is a little bit of air which I injected here. Okay, just a 5 cc of air I can see that here, and it's a very straightforward. So when I'm making a in fluoro, I should not see this length of the what do you call this puncture needle. I should see only the top part only, so that it means it's a bull's eye technique. So it's straightforward. I go inside, I approximate beforehand what's the patient build-up by looking the CT scan of the patients ahead, and I go inside. And after doing that one, after doing I insert, I turn my fluoro to 0 degree, sorry, 30 degree. By looking 30 degree, you exactly know if you are in the calyces, you are in the deep, or you are in superficials. If I am superficial, I'll go little inside. If I am deep, I'll just pull up my needles. By doing so that, it's so reproducible that easily you can even get access even just one puncture. You don't really need to multiple puncture, because this is very predictable way of puncturing the kidney. And after then, what I do is I put my guide wire all the way. I try to put as much as possible. I try to put my guide wire all the way dilate up to the bladder. My guide wire should go up to the bladder, and sometimes I change. I put the different dilator here, the serial dilators, and I sometimes I change my Teramo guide wire to like super stiff, or maybe a Zebra guide wire which is little bit stiffer. And then along with that guide wire, I put my coaxial sheath. Okay, the coaxial sheath is just like a ureter catheter, French 8, and it goes all the way up to distal ureter. And then I have a very nice stiff pathway, and I can dilate up to whatever I want. Okay, up to here, up to here, up to here, whatever. If the stone is here, I will only dilate up to here. If the stone is here, I will dilate up to here. So I will plus my dilators, serial dilators. Okay, step by step, and then I put my M plus. Okay, and after doing this one, it's so easy. We can really do up to proximal third here, up to the like lower calyceal stones. Easily I can go each of the different calyces here, if it's even inferior pole. Okay, and up to I can also go up to the middle calyceal here, up to sometimes up to here, but I cannot go here. This is the only problem if you are approaching from the this one, and might sometimes this might also can be a problematic if you are dealing with the upper pole approach. Okay, so this is because too much torque here, I cannot reach here, but up to here this middle pole, and up to here this inferior pole, up to here all this up to, so nicely I can remove all the stones. Okay, this is very fantastic way of doing PCNLs. So that's what I do it, and usually I left my nephrostomy tube here, because I'm concerned here, because mostly I might puncture the pleura. So if I leave it without nephrostomy tube, and if there is a, let's suppose like bad luck or something, there is a stone stress, or sometimes the the digestion did not really properly position, there might be block. And if that case, if I did not leave the nephrostomy tube, I might have some more problem. The patient might have more pain. Sometimes may have some pulmonary effusions, and there is some kind of like fever, persistence of fever. So it's better always to put a nephrostomy tube when I'm doing the superpole punctures. Okay, but sometimes I also do inferior pole puncture, but I only choose my inferior pole puncture when I'm doing my super mini PCNL. Because in this super mini channel, my concern is, let's suppose if there is a stone here, only this part, I go up to here, I dilate up to here, I use my laser. Because using the laser, there is no retropulsion of the stones. Okay, otherwise if I use my mini PCNL and I use my like a pump, to have the effect to bring the stone down, evacuate the stones. The tendency is this stone might migrate all the way up to here, or sometimes it migrate up to here, sometimes it migrate up to here, sometimes, most of the times they also migrate up here, because we are using the water force in the mini PCNL. So by doing that, it's very difficult. If they still migrate here, I have to put another puncture here, because I cannot reach from here all the way here. It's sometimes difficult. Sometimes doing the stone goes here, and I have to too much torque here. It's very much difficult to do that. So that inferior pole, I use my super mini PCNL up to the only stone, and use my laser, so that and there is a less chances of stone migrations. So when I'm using a inferior pole, I always use super mini technique, because it's very nice, because it has its also suction effect, and it always uses laser, and there is really no chance of stone migration, because there is no the fluid will just push back, because there is a suction also mechanism together with this. And also sometimes I also use mid pole puncture. Mid pole puncture is also a very effective way of doing a puncture, just like a superior pole. It has advantage is you don't have to go all the way up to the kidney, because there is a less chances of having a purulor or complications. Because here what I do is just I look for the tip of the 12. Okay, then in between the 11 and 12, mostly tip of the 12, I insert my needle, and thus which is the superior, the most superficial calyx, I puncture there. Okay, and I puncture this one in my 0 degree. Okay, also. And if there is no fluid come, sometimes I can make the 30 degree and see if I am the deep or if I am superficial. And by looking the 30 degree, I know if I am superficial or deep, so I will adjust accordingly. It is easy to do it. And but this technique I always use mini PCNL. Why mini PCNL? Because mostly if you use a super mini PCNL, the problem with super mini is you there is no access sheath. Okay, there is no emplas sheath there. So you have only one scope, and the emplas sheath is there is no emplas sheath. So if you want to maneuver the scope, is difficult, and since the scope is very friable, you might break the scope. So when you are using super mini, you should be very straightforward to the stone and just fragment it, just leave it. That's all. You cannot really try to manipulate around and go this kidneys, do kidneys, too much different angulation, because there is no access sheath. So if you have access sheath, you have more leverage to move the scope. Okay, so in super mini, I found that if there is a stone here, you can just go there, you can dust the laser, the job was finished. But if you want to go this calyx, but if you want to go upper calyx, if you want to go here, if you want to maneuver inside, there is less maneuverability in super mini PCNL. Unlike mini PCNL, we have a much more mini leverage in maneuvering. Like here, sometimes when we approach from here, we can go all the way up to the inferior pole. You can remove the stones. Also easily you can approach this pelvis. Okay, pelvis and the proximal ureter, and also you can sometimes go up to the upper ureter. So this for the middle pole, mini PCNL is a very effective way of doing a PCNL also. Okay, so how I do my bilateral PCNL? Okay, I have been doing my bilateral PCNL since 5 or 6 days, 6 years, and it is very possible to do a bilateral PCNL from one side. Okay, let's suppose I'm doing a bilateral PCNL from right side. What I do is my preferred approach for bilateral PCNL is always the upper pole, because let's suppose I always do my bilateral PCNL from the same side. I don't change the position, because changing position everything is takes so hurdle. So what I do is I approach upper pole, and also contralateral side also I approach upper pole. Okay, so let's suppose what I do is firstly I do upper pole approach of this kidney. Let's suppose I'm doing bilateral and I start from the right side. I do upper pole approach from kidney, and if my surgery is finished within a time, there is no blood loss and there is an uneventful course, then I proceed to the bilateral side. Otherwise, if there is some problem, I don't do the bilateral. And another thing is, if I have to approach the contralateral kidney inferior pole or mid pole, what I do is I do that side first. I do that side mid pole or contralateral pole first, then only I do the later the upper pole approach in the contralateral kidney. Okay, so what I mean is, let's suppose I have a stone here and I want to approach mid pole, and another kidney has a stone in upper pole. I want to approach right side first. Okay, and from same side I want to approach the upper pole approach in the left kidney. That's how I choose my PCNL. Okay, and I think in the super mini and mini PCNL I don't place nephrostomy tube, but in the standard PCNL, especially upper pole, I always leave a tube here. If you have any questions, I am very happy to share with you any. Thank you.